Welcome, and thanks for joining us to help choose home when care is needed. A podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Merrily Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guests, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and CoreCubed. Today's episode is the beginning of season number 3, episode 1 of season number 3. And these are unusual times, so we are going to start with an unusual podcast in that we have 2 guests today. We have Lora Masci Weagle and Adrianne Mann. Both of these professionals are from HCR Home Care, and HCR Home Care actually operates in upstate New York in 25 counties. And if you don't know your geography, that is the Catskills, Central New York, the Finger Lakes, and the North Country regions. Both of our guests have extensive experience in healthcare and aging, and you will hear much more about the wonderful work they're doing in their communities and healthcare at home as we talk further today. Please join me, won't you, in welcoming Lora and Adrianne to Help Choose Home. Thank you all both so much for joining me today, and I know this is a very busy time in your lives, an unusual time for all of us, so I want to thank you both for being here. And first, let's start with just give me sort of a 10,000-foot view of HCR Home Care, what you do, what areas you serve.
Sure. So HCR Home Care was founded 40 years ago by Louise Warner here in Monroe County in upstate New York. We have 3 business lines. One of them is our certified home care agency. That is the federally regulated home care that we have skilled services that go into the homes with nursing, physical therapy, occupational therapy, speech therapy. We have social workers and home health aides. Typically that's covered by insurance, and patients are seen under the supervision of a physician. We follow physician orders to provide that service. We also have a private duty business line under HCR, which we call our licensed division. That is mostly private pay care. It's mostly aid services, but we do have some nursing services provided under private pay. And in New York State, we do have some insurances that cover some of that cost as well. Our third business line here is a care management business line, which is a state-specific service. They deal mostly with what we call social determinants of health, and they help patients or clients, as they refer to them, access services for housing, transportation, food scarcity issues. If they don't have a provider, they will help set them up with providers. And they sort of fill in the gaps, as I say, between some of this other home care lines.
Primarily behavioral health issues.
Correct. A lot of the clients, one of the qualifiers is behavioral health diagnosis as well. So those are our 3 business lines. We operate solely in New York State. We are in 25 counties, and we also have a management contract where we see patients in 3 additional counties in New York State.
But all upstate New York, the Catskills, the Finger Lakes. The North
Correct.
Country, I believe, is one of the things you all call yourselves in your region.
Correct. And then Central New York as well.
Well, this podcast is being recorded while we are all in most places not actually seeing each other, but you 2 are in the same room together. Does that mean that you are still going into your office and performing work in your office?
Correct. We've actually been here full time still.
You have been.
We have decreased our population within the office setting by 70%, and there's about 30% of us that still come into the office daily.
And what are the protocols that you all have put into place that are, I'm assuming they would be different now under COVID-19, but perhaps not. Do you have specific new protocols you all are using for safety, or did you
Absolutely.
already have fabulous protocols in place?
Well, of course we had fabulous protocols in place, but we've grown them somewhat. So we are practicing social distancing. Each day when we come to work, we do have to sign an affidavit stating that we are free of any illness related to COVID, such as headache, fever, sniffles, cough, etc. And we are also asking the same affidavit from our field staff. So they have to sign a waiver each day electronically, and then that gets sent into our office so we know that they are safe to work.
Good.
We also screen each of our patients each day prior to going into their homes.
And both of you, prior to being in a home care setting, worked in either hospitals or facilities. So are you incredibly happy that you've switched to a home care setting at an appropriate time in your career?
Well, you're not going to believe this, but I started here on March 2nd. After 28 years in the hospital setting, and I was the director of the emergency department. So boy, did I get out.
You got out right at the right time, I think. So do you have emergencies in healthcare at home?
You mean emergency situations with our patients?
I'm just wondering, you have a background and you ran an emergency department. I just wonder, are there situations now where you feel there's an emergency where you're called upon to use some of those skill sets?
I haven't as of yet, but obviously we have acute care and acute needs for our patient population, so they would be escalated and called 911 and sent them to the emergency department. But they don't really use me in that role here. I'm more of an administrator. And I was an administrator, although I was the director for the emergency department at Rochester Regional Health. I was less hands-on with the patient population.
One of the things that I'm hearing around the country is this safety issue, and home care is the least restrictive setting. It's the lowest cost setting, but I'm also wondering about safety. Can you weigh in on the safety right now of patients that are receiving care at home?
Sure. So part of my role, Merrily, is the referrals start with my team, and at the referral process, we actually start our screens on every case. We've built into our EMR system. We actually use the CDC guidelines for the COVID screen. So we identify upfront, are they a suspected case? Have they been tested? Are they an active case? What's the results of that test? That's all documented in the EMR system that we use, which is the electronic medical record system. And that is identified from the very beginning for our nurses and therapists that are going out into the homes. So they have information, they know what type of precautions they need to take prior to entering the home. And even though we put that into the referral, they re-ask those same screening questions prior to every visit. So, we may see a patient 3 times a week, and in between those visits, something could have changed on their end. So prior to every interaction, our clinicians screen the patients. And depending on the responses to those questions, they have protocols that they follow.
And we have provided full PPE for those clinicians that are going into the homes if it's required for a COVID patient or a suspected COVID patient. Otherwise, they're still using precautions such as surgical mask, gloves, hand sanitizer, increased washing of their hands.
This is for a consumer audience. I'm assuming if anyone's reading about COVID-19, they know about PPE, but could you tell me what PPE is, please?
PPE is personal protective equipment. And so when we're referring to that, it is what they are hearing in the news are the gowns, the gloves, the masks that Adrianne was referring to. So we do use that as shorthand, but sorry. No, that's okay. Remind us, Merrily, if we do that again, we'll make sure we explain
right.
And then depending on the patient's diagnosis as to the extent of the PPE that we're utilizing.
And that varies depending on the patient.
Correct.
So what lessons are you going to take with you out of this pandemic that will flow through to just providing your normal health care at home when this is over, assuming it gets over?
It's going to get over. I think it's been a lot more awareness of our patient population in the home care setting and recognizing that they have needs social as well as medical, and ensuring that we're giving them their empathy that they require, their social interactions that they require, ensuring that they're safe, that they're reaching out to their providers we may be that only bridge to their providers at this time. So we'll make sure that we're enhancing that going forward as well. Decreasing hospitalizations, readmissions.
For a consumer who has a loved one with a care need right now in this time, which is such a strange time for everyone, how do they access care at home if they happen to live in the region that you all serve in Upper New York?
Right. So they can reach out to us directly, and we can reach out to their physician, or they can reach out to their physician, and the physician sends us the referral. So they can come to us through either channel. Most referrals come to us through, traditionally, pre-COVID, through physician offices and hospitals and rehab for our certified agency. For our private agency, where people are paying for aid services, often we get direct inquiries from the family members and caregivers right into our intake team. And same idea, they'll go through the process, and once we understand what their needs are, we will reach out to the physician and help coordinate the orders and get everything in place to provide care for them.
Are you finding that people are still accessing information and reaching out for help?
We are. I will say...
Let's talk about what you've done.
Right. So I will say the first two... So I consider this week 7 of COVID in my time frame. I would say weeks 1 and 2, we definitely saw a pretty drastic slowdown. Everybody, including us, the hospitals and the physician offices, were on a daily, sometimes hourly basis, adjusting their processes and protocols to make sure we were keeping our staff and patients safe. So a lot of time was spent on that. I would say the second wave was there was a lot of fear about having home care come into the home, and we did a lot of work around helping to educate our physician offices, our patients, and our own staff so that everybody was aware that we do now have processes in place to keep everyone safe. Once people kind of got into this, I would say the third wave of this experience, that's when we started to really see people reaching back out and asking for services. My team, who does a lot of the outreach, we've done a lot of work directly with physician offices to help them understand what we're doing, because understandably, everybody wants to understand what we're doing to help keep our staff and patients safe. And also, there are some risks involved if patients actually do need home care and they're declining or refusing services, which we were seeing more of in the beginning. That has decreased quite a bit. But patients that are, with chronic conditions, we often have patients come on and off of services, and they may be identified as needing home care either through the hospital or the physician's office. And if they weren't going to the hospital or the physician's office, they're home, possibly declining and really increasing their risk of an acute situation where they would have to go to the hospital. So we've done a lot of work with our physician office population to help them know, what we're doing. But then in addition to that, we reached back out to patients who we discharged in the last 90 days. And we have been doing calls into every patient's home, checking on them, just generally checking on them. How are they doing within the COVID isolation experience? And then if they happen to need services, we're a touch point if they need to call us back, or we have identified some patients at that point that actually needed to come back on services right away. So to date, we've done over 1,500 calls into the home, and, we've identified quite a few patients that need services or just appreciated the call and just didn't need us at that moment. But we're happy to have a call from an HCR nurse and know that if something changes on their end, that they can reach back out to us.
That's absolutely a wonderful program. Is that a program that was in existence beforehand, or did you implement that just with this COVID-19 situation?
There have been some initiatives out there, but this one in particular was specifically driven due to COVID. When I think about my role in helping make, ultimately my job is making sure patients have access to our services. And when the traditional channels that they come to us by are closed down or minimized, we really had to sort of rethink how they can access us. And so we reached out to them. And these are patients that were known to HCR, familiar with our services, maybe don't need us in this moment, but, really appreciated that call.
And there's also the opportunity of the patients that are maybe decompensating at home because they're not having the interactions. People aren't out in their homes. Nobody's seeing them. Maybe PT needs needed to be resumed. Looking outside of the box. We've also initiated or increased our telehealth utilization for our patients as well.
Can you talk to me a little bit about telehealth? Because we are hearing so much about it in the news. Of course, within the industry, I know everyone is looking for ways to have a presence in the home to keep the patient safe. So what kind of telehealth are you using, and had you used it before, and has it greatly expanded under this lockdown we're in?
You can speak. So we use Medtronic, and we had a pretty robust established program prior to COVID, we're happy to say. So we have nurses, HCR nurses that actually monitor directly, and patients with chronic conditions. Often, the first diagnosis we typically think of for telehealth monitoring is congestive heart failure. These patients' symptoms can fluctuate rather quickly on a day-to-day basis, and so the monitoring takes their weight, it takes vitals, it alerts our nurses in real time if there's a change in any of their vitals. The physicians can set parameters, so if they want us to say, within a 2 to 3 pound weight gain, they're okay, but anything outside of that over so many days, then we would need to reach out to them and possibly change a medication or have some other type of intervention. So the telehealth is really it's utilized in many ways, but, that was really pre-COVID. That was a lot of how the program was used. But since COVID, we've had obviously a lot more focus. There have been times we've received direction even from the state of New York Department of Health sometimes to evaluate, our visits. Do these need to be an in-person visit, a phone visit, a telehealth visit? And I know Adrianne can probably speak to that. She's working with her branch directors to help make sure that they're utilizing those appropriately as an additional tool to make sure we can closely monitor these patients.
And we're doing drop ship so that we have the ability to get them into the homes, the devices themselves into the homes without us having to actually go into the home. And that's a lot nicer for the patients who are nervous about having people come into their homes.
And in that drop ship capacity, is the device easy enough to use and install that a patient can actually do that?
Correct, for the most part.
And we are happy to go. I mean, we do set up a lot of patients, and we have.
It's just an extra option if that is something that we need to do. Obviously, we would go into the home,
right,
but that is an option for them. We've also set up some Zoom meetings with our physicians, per se Zoom, so that the patients and the physicians can have a face-to-face. We've helped to connect them in their homes as well.
That's fabulous. So it sounds like this experience is solidifying some processes that were used somewhat before, but now are being used more. But what I'm also wondering about is your relationship with the physicians. I know where I am, a lot of the physician offices are closed, except for emergency. So are they still able to recommend home care for people, sign an order, and intervene?
They are. We've actually seen an increase in our community-based referrals, partially, I think, because of our outbound, our call initiative. But what it did, I will say the first few weeks, it took a little bit for the physicians to sort of get organized and mobilized. But
initially, they didn't want us going into the patients' homes either.
Right. Everybody just wanted to be there.
They were telling the patients not to let the home health nurses in.
Exactly. So we did a lot of education, and I think that the physicians, we have, really great relationships with our medical community here, and we sent letters to thousands of our providers along with our protocols so they could understand what HCR was doing to help keep our staff and patients safe. And we have actually collaborated with some of our physicians locally who wanted to take advantage of the telehealth approval for the physician, the video visits that are approved, because they have patients that can't or won't come into the office. And so we've been able, as Adrianne mentioned, because of our EMR system, our electronic medical record system, it's pretty sophisticated, and we can actually add an additional code for the clinician so that when she goes in to do her regular visit to see the patient, she can also help facilitate a call to the doctor that the patient can get their encounter established during that same time frame. And it's that level of coordination and collaboration that's really been a really nice silver lining from all of this is, people are kind of getting really creative and working together and finding ways to meet the patient's needs in their homes more than ever before. I mean, that part is exciting to be a part of.
Absolutely.
Don't you think?
Absolutely.
Yeah.
Definitely thinking outside of the box and how we can meet our patients and see them, but maybe not physically or face-to-face, but looking outside. We've also created templates within our EMR to have those phone visits, and it's not just from the nursing, but it's all disciplines. So we have the templates for the physical therapist. We've had the social worker, the speech, the occupational therapist. So if they are not allowing us to go into the house, we don't necessarily have to close their case, but keep them open with at least a touch point of a template of a home visit via telephone.
Well, I will tell you that listening to the two of you and the measures that HCR Home Care has taken to assure the safety of the patients and to increase your communication and also to increase your coordination with referral sources, it sounds like you're going to come out of this COVID-19 scenario in a better place than you went into it. And that's the silver lining, I would say.
I think so.
Yeah.
It's exciting. It's a good thing. I mean, you got to take the good with the difficulties, correct?
Yes. But, there are so many industry issues in healthcare at home that seem to have been fought for decades that now some of those issues are being allowed, telehealth being one of them, having people, other levels of medical personnel besides just medical doctors be able to sign orders. So are you seeing that freeing up some time or allowing a more streamlined operation as well?
I mean, I think anytime you can lift some of the restrictions that we're on, I know nurse practitioners and PAs have understandably, wanted to be recognized for overseeing plan of care for the certified agency for a long time. And that's a piece that I'm really hoping stays. Any of these kind of relaxed guidelines, we're hopeful that they stay. It's really helped us to access patients more quickly. And really, I know that's not the topic of this show, but, there's a shortage of primary care providers nationally.
Yes.
And so being able to utilize nurse practitioners and PAs in that capacity is, I think, something that home care as an industry definitely needs and wants and is in support of, for sure.
It also sounds as if, at least in your area, this communication with the medical professionals has eased a little bit. So that is certainly something that has been an issue in the past, and hopefully in the future, people will recognize that choosing healthcare at home is a more viable option in lots of different scenarios. So would you agree that that has a possibility for the future?
Absolutely.
I could listen to you all. I feel so comforted. I'm glad I don't have an issue that I have to have home care for, and I'm not in New York. But I feel very comforted after speaking with you all today. Is there a question that I did not ask you that you would like to answer that would help consumers in understanding how to choose home when they have an option for care?
I think as long as we're paying attention to the safety of our patients and optimizing their well-being and keeping them home, if that's the comfort level of the family and the patient, then I think that that's something that everybody should look into. I don't think people realize that there are services available to them to keep their patients or family members at home.
Well, let's hope that if there is a silver lining and a positive out of this whole COVID-19 situation, that will be one of those positives. So, Adrianne and Lora, thank you so very much. This has really been an enlightening interview, and I really thank you for your time. And I'm going to let you get back to your busy lives because I know that you have patients to care for today. Thank you.
Thank you.
Enjoy your day.
You're welcome. Bye-bye.
Bye. Thank you so much for listening today, and a special thanks to our sponsors and partners, the National Association for Home Care and Hospice, Access, and Core Cubed. If you have not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. We are now also on Spotify. Like and follow us on social media, and join us, won't you, to spread the word and help choose home when care is needed.